So tonight is a back to the basics, kind of a Zoom. And even though some of you might have a lot of experience with dentures, some of you might only have a little bit of experience with dentures, I think that it's always nice to hear from someone new and someone different. And maybe there'll be a small tidbit that you can take back. So I know that a lot of people think of complete dentures as being outdated, and they think that now everyone just goes on to implants. But for those of us who see these patients, we know that's just not the case. So we still, even if someone's going to have a full mouth rehabilitation on implants, I still go back to the basics of my complete denture. And when I'm thinking about where I'm going to reconstruct that patient's vertical dimension, what do I want their teeth to look like in space, and how am I going to get them really rehabilitated? And depending on where you went to dental school, you may have had a lot of experience with dentures in your training. You may have had a little bit of experience in your training. So this lecture really is for everybody. And we'll go through the basics just to make sure that we're all really comfortable and feel confident helping our patients with these. So in today's lecture, we're going to go over ways to maximize our aesthetic results. We'll go over different impression techniques to help us minimize our chair time. And we're going to help identify common problems in delivering our complete dentures and also common issues that patients come back with. So I am just going to give me 1 second because I want to stop seeing myself in this top corner. Hold on. Okay. So, all right. So there's multiple ways when we're looking at our denture patients that we can achieve beauty, but sometimes it's hard to know where to begin. But it wouldn't be a fundamentals lecture if I wasn't speaking about aesthetics. And we all learned in dental school about that golden proportion for aesthetics, right? The Fibonacci sequence, we see it in nature over and over again. But when you're thinking about that and aesthetics, it brings us to like the more fundamental question of what is a smile in our patients? Is it only our patient's teeth? And I think for all of us, we know that there's more to someone's smile than just their teeth. It can also include the patient's lip support and what frames their teeth. So, how much are the patient's teeth affecting the way the patient's lips look? And when I'm talking about lip support, we can think about it from multiple points of view. So I can think about it from the profile view. So when I have this patient with his denture out and his denture in, I can look at his nasolabial angle. So the corner that comes from under his nose down the philtrum of his lip, and see how that angle becomes smaller or more acute when he has teeth because it actually pushes the lip forward. So a lot of times people might think that that's coming from the flange of the denture, but actually the best nasolabial angle support should come from the tooth position. The other area that we can look at is the lip contour. So you can see from the left photo to the right photo, it already looks like this patient got a couple cc's of lip filler put in there. And it's just the difference of having a denture there to bring that lip fullness. He looks a decade or two younger in the photo on the right. And that's really because of that lip support and facial support that he's getting. So there is, of course, a limit. So sometimes patients will say, "Oh, I just saw how much lip support you gave me. Can you give me a little bit more?" And as a thin-lipped person, I can understand where they're coming from, but there's a limit. So you don't want to overcompensate, or you're going to end up looking like the Godfather by just packing it into their cheek. So I always tell the patients that I can do as much as I can with your teeth, but sometimes it does go into this land of filler that Americans seem to be so in love with nowadays. So I always tell them I'm not a dentist. I'm a dentist. I'm not a magician, which is what my mug says, but I understand your confusion because we can do some really amazing before and afters, but that we have to limit ourselves just a touch. So of course, we know tooth display is what we are always talking about with dentures. And as dentists, we always want to jump right into the teeth. So that's why I started with the lips. So when we're talking about tooth display, we want to think about how much tooth is displayed at rest in our patients. And this is going to vary depending on the patient's age, their gender, and the length of their upper lip. So that area that's being framed by the lips is going to move around. So patients who are younger or are female patients or patients that have a very short upper lip are going to tend to show more of their maxillary teeth compared to our male patients who are older or have a longer upper lip, they tend to show their more of the mandibular teeth. So for them, their social six might be from 22 to 27. Those are the teeth that show when they're speaking. So in terms of our average incisal display in gender, women tend to show about 3.5 millimeters on average of their maxillary teeth, and men only show about 2. And that is from a very famous study by Vig in 1978. And those numbers we still cite in the pros world all the time. So we're going to see a lot more maxillary tooth on a woman than on a man. And you can actually break it down by decades. So in their 20s, women show more, and then 60 plus, they might show none at all. And in terms of the centrals, they go from showing barely any central at rest to showing a lot, 3 millimeters of their mandibular central incisors. And although that is true, when I have my older patients in a denture, just because they are 60 or 70 or 80 or 90, doesn't mean I can't give them a little bit more incisal display. So what I'll usually do is give at least a hint of incisal display for pretty much every patient. Just because as long as we're improving their smile, just like we might go a shade lighter than they would be naturally, we can give them a little bit more youthful appearance of their teeth. When you're measuring their lip length to figure out how much tooth display you should have, you want to measure from the base of the nose to the end of the upper lip. And obviously, the more lip you have, the less tooth you would show naturally at rest. Because you also want to think not just about the length of their lip as well, but also the mobility of their lip. So someone might say, oh, I want to look more youthful. I want to show my tooth at rest when I'm not smiling. But if they smile and they have a very mobile lip and it moves up a lot, you don't want them to look like they have massively long horse teeth. So that's why we're going to go over several different parameters today. And I want you to kind of weigh them in your mind as you're making your decisions about where to set the teeth so that you can come up with what's best for your individual patient in the chair. So parallelism, I think, is one of the most overlooked things in doing any sort of full mouth reconstruction, including dentures, but it's one of the things that's sort of the dead giveaway to teeth being fake. So naturally, we want things to be parallel and we want it to be compared to the patient's pupils. So I don't like to actually use a level when I'm trying something in my patient's teeth, unless I also have something to level compared to their head, because a lot of patients sit with their head turned one way or the other. And if you make their teeth parallel to the floor, it might not be parallel to their face. So don't get tricked if their head has a way that they tend to tilt, or some patients tend to have a crooked smile, one side always smiles higher. You want to make sure their teeth are parallel to their eyes. And that is what's going to look the most natural as the patient is speaking and just going about their daily life. In terms of from the side profile view, there's another line that we want to stay parallel to, and that's the ala tragus line. So that goes from the ala of the nose to the tragus of the ear. And some people will say, is it the top of the tragus? Is it the bottom of the tragus? Is it the middle of the tragus? I have gone on a deep dive on this. I have found literature articles that cite each one individually. So I use a little bit of discretion here based upon the patient's individual nose and ear anatomy. But the most important thing you want to remember is to say parallel to or slightly higher than this line. Because when we lose sight of parallelism, that is when we give away the fake teeth. That's when we really get that false tooth appearance that makes people know that person has a denture. So when we're talking about parallelism, we have to talk about can't. So can't is the absence of parallelism. And the little way that I remember it is it's when you can't get parallelism, you have a can't. And you might think, will someone actually even notice if my patient has a can't? It's actually more important that the midline is straight than it's on center. Up to 2 millimeters of deviation in midline is not even noticed at all by lay people, and a lay person tends to accept up to 5 millimeters of deviation from midline. But only 2 degrees of cant is considered acceptable to a lay person. So I can move my midline over by 2 full millimeters and no one will notice. But if it's canted by 2 degrees, they will. And you might say, well, what's 2 degrees of cant? The text is sliding now, is 2 degrees of cant. So it's a very small amount, and you can see how obvious it becomes as you go further away from midline. So if you learn one thing today, it's that you simply can't. You have to keep it parallel so that it looks the most natural, and that will make it be a lot easier to do any other aesthetic thing. So a lack of parallelism is hard to hide, but other things like a slightly off midline, you can hide that ill. So what can you use to avoid having a cant? So you can use a fox plane, which is a very inexpensive tool in the toolbox. You can get them on eBay for under 10 bucks, which I'm sure means that all the dental suppliers sell them for probably 100. But it's just a flat piece of metal, and it has areas so that you can compare your occlusal plane to the middle portion, your interpupillary line to the portion outside the patient's mouth, and the allotragus line to the portion that's going from their cheek to their ear. You can use this fox plane, and then you can put a tongue depressor parallel to their pupils to make sure that you're staying parallel, and then parallel to their allotragus line. But if you don't have a fox plane, it's okay. Sometimes I just use a tongue depressor and a tongue depressor, and it can do similar things. Sometimes it's just nice to be able to look at it all at once and know that you're touching the entire rim. So here's one of my residents that I coerced into taking this photo. And here you can see what a fox plane looks like in his mouth compared to his pupils. And so we were seeing if his mom got her money's worth out of his orthodontic treatment. So we can see here that he's not parallel to the allotragus line. He's actually a little bit lower than that, but he's still a very good looking guy. He married a beautiful woman, so it worked out for him in the end. And here we can see another one of my residents who has a very acute angle of her allotragus line compared to the fox plane. And you can see how I line up for parallelism to the fox plane. So it's a very simple, quick thing that you can do. And you can do this whether you're doing fixed or dentures, but I do this step with my wax rim to make sure that my wax rim is perfectly parallel, because then I can send my wax rim to the lab and tell the lab to set my teeth. And I know that they can then follow my scaffolding, because my wax rim is my blueprint for my lab to follow. So if my wax rim is canted and I just mark on straight midline, once the lab sets one tooth, their reference plane is gone. What if they mark one tooth and they get a phone call and step away, and now they don't remember where they're supposed to be? So I like to make sure that my wax rim is totally parallel to my allotragus line and my interpupillary line. Once I've set my wax rim up, I have the patient smile with their mouth open, like a ha 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 kind of a smile, right? An Instagram influencer smile. So you want them to do that, because I want to make sure that I don't see the occlusal plane of their maxillary teeth in the posterior. So when you're thinking about that, the reason why the allotragus line parallelism or slightly acute angle is so important is if you don't do that and you tend to drift down, which is, I would say, the most common error that people who don't do dentures as often make. You end up seeing the occlusal surface of the patient's maxillary molars. And I see a lot of patients with amalgams on their second molars when they're in the chair laying back. But when they're just talking to me and laughing, looking at me straight on, I should not see if they have an MO amalgam on 15. So keep them in the back of your mind as you're making your wax rim. When they smile and look at you with an open mouth like that, I don't want to see their occlusal surfaces. So I don't want to see the occlusal portion of that wax rim in the posterior. So buccal corridor is the next area that I like to look at when I'm setting up my wax rims. And that's my cheek space. And I want to make sure that it's even bilaterally. So this is the shadowed area between the patient's cheek and their teeth. So how large is that hallway essentially? And sometimes we can end up with one side looking wide and one side looking narrow, and it makes the face look unbalanced. Sometimes it's because maybe the patient had a large infection or abscess on one side, and so there was more bone loss. And so your lab might have made your wax rim be over the bone, but it's not going to look right. So we can fudge it a little bit on the maxilla and push our wax rims to be slightly buccal to that ridge, and you'll still have good balance in your denture and stability. But you really want to make sure that this cheek space is even on both sides. And regardless of the width of your patient's smile, it should be even. So some people show second molars when they smile. So I always cite Julia Roberts. She's got a huge broad smile. It looks amazing on her. You do that on someone else, they look like the Joker from Batman, right? It's not good at all. So there's not one size fits all, but just make sure that you trial different things, see what complements your patient's face, and then just make sure that you don't have Julia Roberts smile on one side and you can drive a tractor trailer down the other side of dark space between their cheek and their teeth. In terms of tooth position, we want to think about where do we want our canine to be, our midline to be, the highest smile the patient has, and how wide their teeth are going to be. So these are areas that I want to mark on my cat, on my wax rim, because I want to be able to communicate with my lab on the rim as much as possible and not on my lab script as much as possible. I'll put things on my lab script as well, but I know that the lab technician is going to pick up my wax rim. They're just going to get to work. And if it's right there in front of them, there's going to be less back and forth between you and your lab. So I mark my canine location, which can vary depending on you can use different things like the inner corner of the eye, the outer ala of the nose. Some people use the outside of the patient's pupil, iris of their eye. But again, that I would say varies depending on your patient. Some people's noses are super wide, but their mouth isn't that wide. So there you have some wiggle room there. The midline, I always mark my midline compared to their whole face because a lot of us have crooked noses, and I don't like to tell patients, oh, your nose is crooked, right? Nobody needs to hear that. So I take a piece of floss and I look from in between their eyes is right. So most people's eyes are centered on their head. So you go to the right in between their eyes and you'll use that as your reference point and hold a piece of floss away from the nose so it doesn't fall one way or the other. I'll mark my midline and I mark my high smile line as well. And with my lateral incisors, I also, as I'm setting my teeth, I don't want my laterals to be completely flat compared to my central. So nowadays, I find a lot of patients are coming in, they are asking for this. They don't want any embrasures. They're seeing a lot of veneers on Instagram or social media, TikTok, and they want to have what I call the Barney tooth, Barney the dinosaur back in the day. He just had a one white tooth that was flat the whole way across. So I talked to them about how aesthetic it looks to have a little bit of variation. And when they're not completely sure, my go-to natural looking smile that I show females is Kate Middleton because her smile is absolutely gorgeous and it has some natural variation of lateral incisor position. The other thing I look at is the approximate height. So the occlusal plane at the patient's premolar area ends up being about even with the corners of the lip when the patient's at rest. So how do you get the patient to be at rest? Because if you just say like relax, they can't relax. It's like when you tell a patient right after you finish an operative, you're like bite normally and they bite like this. And you're like, you've never been like that before in your life until right now, right? So if you tell someone to relax, they don't know what to do. So I tell someone when I want them to relax, I have them lick their lips and then I say, just pretend you're watching TV. And that tends to work better than any other thing that I ever read in a textbook. I just say, pretend you're watching TV because that's like the universal thing that we all know how to do very well. And so when they're at rest, the top surface of their lower premolar ends up about even with the corner of their lips. So then that brings us to talking about the lower lip. So sometimes it's like the forgotten lip, right? We talk about upper lip display, everyone's getting their upper lip filled, but the lower lip should also frame the smile. And when our maxillary teeth are too long, they can end up biting their lower lip or end up with really poor aesthetics. So I really want to trial this out because sometimes maybe that's how I can guide my buccal corridor. I know if their canine and first premolar are hanging over their lip like a fang, I got to tuck it back. It's encroaching too much. It's going to be uncomfortable. We all know once the patient bites their lip, they can't stop because now it's swollen or it just doesn't look good. The teeth look like they're falling out of their mouth or like they have perio disease. And you want to make sure that it really is framing the smile. So the upper picture just looks way too flat. That's how we know this wasn't set like a normal smile. And on the lower picture, the canine's just a little too long. And so the teeth don't look like they fit in someone's mouth. Now we're going to talk a little bit about making a good first impression. So the initial impression is really critical to the success of the final denture. So I still do two-stage impressions for most of my dentures. And you want your initial impression, even if you're going to have a custom tray and border mold later, you want to overextend that primary impression as much as possible so that your custom tray reaches all borders and gets very overextended. So sometimes I think, we're all rushed for time, right? And so you'll get an impression, it's got most of it. There's no retromolar pads, there's no hem or notch, whatever, move on. And now you're going to spend so much more time border molding, and your border molding material and your definitive impression material is way more expensive than your alginate. So just take another alginate. And I like to use periphery wax to extend the borders of my stock tray. So I will add that. Ours is blue. It's just the normal periphery wax to add to the edge of the tray so that I know my tray is reaching all the boundaries of my patient's mouth, because, I'm using a stock tray, and they come in small, medium, and large. And so it's not everyone is small, medium, or large, and I need to kind of adjust it a little bit. The other thing I sometimes do with my stock trays is, even if they're not thermoplastic trays that are meant to be molded in heat, all plastic melts pretty well. So I keep a bowl of water so that if I set something on fire, I can drop it in. But I'll flame that regular thermoplastic tray if someone has a really V-shaped notch, and I'll just squeeze it together a little bit and then dunk it in the cool water to cool it off before I put my alginate in there. The other thing that I sometimes do is I will put alginate in a syringe to capture the depth of the vestibule. So you might have like the AccuDent material two-step alginate impression technique, but even if you have just regular stock alginate, you can take a very large syringe, or if you don't have that, if you have a monoject syringe in your office, you can cut the tip of it, and then you can squirt alginate directly into the depth of the vestibule so you're going to capture all of that area. I like to do a secondary impression on most of my dentures, because when I border mold, I know I'm going to get a great fit, and I can trial if I have suction, and that just makes my insertion appointment so much easier. Sometimes I still actually use green stick compound, or other times I use fast set PDS, depending on the patient or their individual arch. The reason why I like compound is because as a prosthodontist, I don't get referred patients who have any visible arches. They're usually like invisible, flat arches that really lend to the name plate for a denture. So compound is a little bit forgiving. If I don't have a great first impression, I can really build my compound out. But PVS works really easy. It's clean. I don't need to set up as many things. I don't need to have flame out. A lot of my maxillaries I'll use PVS on because I can get a really good initial impression. And it's just a little bit cleaner to my assistants like it better. There's less to sweep afterwards. So the biggest thing is trying in the tray. So you need to try the tray in before you start border molding. So I put the tray in the mouth without any material on it, and then I rehearse my border molding movements for two reasons. One, my patient's going to know what we're going to do before I'm putting my goop on there, especially if my patient's hard of hearing, they have trouble following instructions. You got to get a test run. But the main reason I do it is because if my tray is moving in my hand when the patient is doing their border molding movements and there's no border molding material on it yet, my tray is overextended and I have to trim my tray, because my tray should be short of my borders when they're doing their border molding movement. So my border molding material captures their movement. So you need to just take out your acrylic burr and trim that back until nothing is moving during those movements. Of course, it's not going to have suction, but I'm holding with stability on both sides while I'm doing these movements. So now we're going to go over the areas that how I border mold. So if I'm going to do my buccal and labial vestibules, I'm going to have the patient pucker and smile to capture that area really well. You can also have the patient, if sometimes they have trouble with puckering, you can tell them to like suck on your finger like a straw. If they don't know how to smile, I tell them to like grimace, like show me your teeth, like you're a tiger kind of a thing. And that's another way that I can cue them to get them to do what I want them to do. I personally don't pull on patients' cheeks and drag them down a lot unless the patient is very, very unable to coordinate their movements because of a communication barrier. Maybe they're super hard of hearing. Maybe they have some cognitive issues and they're falling asleep in the chair. Their denture accidentally got thrown away and they really need a new one. Then I'll kind of manipulate it just to make it easier on them so they don't have to go through so much. But I like to have it be the actual way the patient is going to function. The way that my mouth moves when I'm puckering and smiling is nothing like the way that I don't eat with a thumb in my mouth. So I don't want to put a thumb in my mouth in order to kind of demonstrate how the denture is going to function. The hamular notch is a really important area to capture in a denture, and I would say it's an often forgotten area. So this back area is has ligamentous attachments coming into it. So in order to see how what its limits are, you really need to have the patient open and close as you're border molding the maxilla in the posterior in order to get not just the notch, how deep it goes up, but how shallow it becomes when the patient opens. Because when the patient opens, that pterygomandibular raphe that's attaching all the way down to their retromolar pad in the back. So what you're looking at when you're going to do your blocks and you're going lateral to that raphe, that string is attaching right to your hamular notch. So you need to make sure they're opening and closing. So when the patient opens their mouth, their denture doesn't just pop out back there. Another area that we can sometimes forget about is that the space of our denture is bounded on the upper jaw by our lower jaw. So when the patient moves their lower jaw left and right, the coronoid notch of the mandible is hitting and limiting that buccal vestibule area. So I want to make sure they move their jaw left and right. This is the same reason why when you're prepping a second molar, you'll get a little bit more space if you have the patient close halfway and slide their jaw, right? Suddenly there's more room for your mirror or your handpiece. Same thing we're thinking about here, but instead of seeing how big the space gets, I need to know how thin does that space get so that I make sure the denture is not popping out when the patient moves their jaw side to side. Now I want to think about the posterior palatal seal. So this is another thing that a lot of people have learned a lot of different ways to do it. So I like to have the patient say, ah, ah, ah. And I don't like them to sing ah, like ah, because when they sing ah, it moves at the beginning and then it's just vibrating. I want to actually see it, if you can see my hand, how it pops down like ah, 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 ah. And then I can see the area where the soft palate is transitioning from movable tissue to immovable tissue. And that is the posterior extent of my denture because my denture cannot be on tissue that's going to move when the patient says ah, or else they're going to say ah, and my denture is going to fly away, right? We don't want that. So you can use a T burnisher, which is on the screen here. I think it's kind of a misnomer. It looks like a Y burnisher if I was naming it, but I haven't invented anything. So who am I to speak? But you want to use the ball portion of it to squish the tissue and see where from that vibrating line forward is still squishy. And that's going to be that half butterfly appearance. And so this is the area of soft palate where we have depressible tissue, but it's not movable tissue. And that's going to be our posterior palatal seal area. So we're going to remember it's going to thin, feather to nothing as we move anteriorly, feather to nothing as we move into the hamular notch, and feather to nothing in the midline because our patient's median palatine suture is under there. That's a bony projection. That's usually pretty thin layer of tissue over. And it gets uncomfortable if we push on that too hard. But in the other areas, you need to see how much squish there is to the tissue. Some patients are very depressible in their tissue. They might have 3 or 4 millimeters of depressibility. You can technically, if you read a textbook, carve up to half that depressibility, but I usually don't carve that far. But other patients, sometimes you have, a patient that's 95 pounds soaking wet, they might only have a 0.5 millimeter of depressibility. So if you don't mark this, and if you don't carve this yourself, and your lab just arbitrarily carves a 1.5 millimeter PPS on every single one of your dentures, it might cause sore spots for your patients. And that's an area that I don't really like to adjust. So I like to just get it right the first time by marking it myself. Another area that's a nice clue for you when I look at my patient, do you notice how the color of the tissue is different? So in this depressible area, we have salivary glands and adipose tissue. So our fat cells tend to be yellow, right? And our gingiva tends to be pink. So when you have that yellow and pink mixed together, it creates a peachy appearance. And then it kind of is like a hint for you. This is probably where my PPS is going to be. And then you'll have that. Some of you may have learned it's always before or always behind or always at the fovea palatinae, which are the two little indentations in the back of the palate. But when they've done studies, they actually found that it does vary in patients. But what I do is I look at my individual patient's fovea palatinae and I look at where is their vibrating line. And then I'll just measure in the mouth. Oh, it's 2 millimeters behind. Oh, it's directly at. And then instead of using a Thompson marking stick, because A, I'm impatient, and B, I always feel weird coloring on adults. I don't like to mark it in their mouth. I'll actually look at it in their mouth and then mark it on my cast and look back and forth and use those reference points to guide me. And then I'll measure with a perio probe, not the depth of the PPS because that would hurt, but the length of it. So from posterior to anterior, oh, it's about 10 millimeters of area of depressible tissue. It's 12 millimeters of area of depressible tissue in this individual patient. And then I like to carve my own cast. I like to use a discoid cleoid to do that. So then moving down to the mandible, again, in this posterior area, the retromolar pad is so important and so frequently trimmed off of our models, forgotten in our impressions, might not have been in the initial, so then your custom tray is way short of it. But we really want to get that retromolar pad, and we don't want to just get it at rest. We want to get it when the patient's opening and closing, because again, that pterygomandibular raphe is inserting into that area. So we want to see what's the limiting factor of it so I can try and achieve some suction in my mandibular denture. So I have the patient open and close to get that region. And also to get the area where the muscles are attaching into on our buccal shelf, I'm going to have them open and close against pressure. So I'll tell them open, and then I'll kind of push halfway down and say close against my fingers. The benefit is in a complete denture patient, they usually don't have teeth on top, so they're not going to bite your fingers here. So it's the one time I do encourage patients to close against my fingers. And this way I can actually see how are those muscles inserting into my buccal shelf, because that's a limiting area in the posterior buccal vestibule of my mandibular denture. When I'm doing the lingual portion in the back of my lower denture, I want the patient to move their tongue into the opposite cheek on each side. And then I will have them also push their tongue against the incisive papilla. So it's a little bit different. A lot of people like to have the patient stick their tongue all the way out. I personally don't like to do that. I find it makes an overly shortened denture. And while, if you're a grandparent and you have a grandkid, you might stick your tongue out a lot. Most of us aren't walking around sticking our tongues out at people that often. And I would rather get the denture extensions to be as secure as possible. So if they push their tongue against their incisive papilla, so I tell the patient, you feel a bump on the top in the front behind your teeth if they have teeth, or if not, I'll just put my finger right on the incisive papilla and say, push your tongue there as hard as you can. And I find that gets a much more defined without overly thinning my denture flange in the distolingual area. And I'll also get a very nice, accurate depiction of what the lingual frenum looks like. If they're not able to do that well, then I'll have them lick their upper lip or stick their tongue out. But if I do see they push their tongue hard, I find this creates a lot better success with that lingual area. The other area, of course, we're going to do puckering and smiling on the lower, just like we did on the upper, to shape especially that labial area. And again, you can have them suck on your finger if they're not doing it well. And at the end, this is what my border molded dentures look like. I'm going to have suction with them in if they're wet. If it's dry, nothing has suction. And if you don't have suction in your maxillary border molding, reshape it, because if this is really your trial area here. If you don't have suction in a definitive denture, in an immediate, you can let it slide. It's hard to get suction sometimes, depending on the patient's anatomy with the immediate impression. But on any traditional CD, you should be fine to get suction at this stage. And then I'm going to go ahead and I like to place a vent hole in the area of the rugae. I find this is more important than tray stops, because a lot of people have some redundant squishy tissue in this area, and I don't want to overly compress that. And then when I paint my adhesive on, I need to make sure the hole didn't go away. So a lot of times I'll go through the trouble, I'll make a hole, my assistant might paint some adhesive, they hand it back to me, the hole's closed again, right? So just poke it out, no big deal. But you want to make sure there's a way for your impression material to flow through that hole so I'm not squishing that tissue out. Before I used to do that, sometimes I'd have patients that had a lot of redundant squishy tissue there, and the denture goes in, it suctions, and all of a sudden it's like, and it's popping out, because all of that tissue wants to be free again, right? It's like when you get home from work and you just want to take your shoes off, right? If you're wearing jeans, what's the first thing you do when you get home? You take your pants off, right? Your maxillary anterior, it's like that. It's like throwing that pair of jeans on the chair. So that's one area that vent hole helps with. So in terms of shade, teeth being too bright is another classic giveaway. for fake teeth. So I always tell my patients, I am selecting a shade for you that lets people admire your smile and not your individual teeth, because I don't want someone to go, wow, your teeth look so nice. Why? And then get really close and then go, oh, because they're plastic. Right. So I tell them, like maybe we'll step back a little bit in terms of the shade and find something that really fits you. And I never, ever, ever hand them the whole shade guide. Right. So I think we all know that we've all gotten burned once. The patient sees, the Kohler white, they want to look like a bathroom sink, but we don't want to do that. So, in terms of delivery concerns and what can go wrong, I would say the biggest nightmare that we all have is gagging. And a common error by dentists is trimming the denture because the patient gags. So you're like, oh my gosh, the patient's gagging, the denture's too big. I'm going to make it smaller and they're going to feel so much better. And this frequently makes the issue much worse. So I would say you want to make sure that you're not making the denture become more noticeable to the patient by shortening it. So I actually searched on Reddit like mildly infuriating things, and this is what came up. When your sock falls into your shoe halfway, right? It drives you nuts. You spend all day with socks on your feet and you don't think about them at all. But if it slides halfway down your foot, you cannot stop thinking about it, right? So that's what happens with a denture. If someone's gagging and then you make it shorter, they're just going to gag more. Now that sock just went further up their foot in their shoe, right? So I like to instead thin the denture. I've actually seen patients come to me, they had a denture done outside. They were gagging, so the doctor shortened it, they shortened it, they shortened it, they've come in with it shortened to their premolars. Of course, they're going to notice it because the more anterior it goes, that's where our tongue has so many receptors to notice what's going on. So we can avoid this by setting the teeth in the right location from the start. And that's a great way to prevent gagging. So you need to make sure there's room for the tongue. So when you do your wax try-in, does the tongue look like it's caught? Does it look like it's totally bound up? So you want to set those lower teeth over the ridge as much as possible and following the ridge, not going back at too much of an angle. So they're like stabbing the tongue. And another thing I can do with some of my patients is I will practice with topical. So I had a patient who, no joke, would gag when I started to like walk towards her and then like put my finger on her lip, she'd be gagging. So for that patient, I know gagging is psychological because that patient eats food every day, right? They put food in their mouth, they don't gag. They put a spoon in their mouth, they don't gag. So for those patients, I talk to them about it and I'm not like demeaning them because they're truly feeling gagging. They don't want to throw up, but I tell them we have to trick your brain into accepting something in your mouth. So I have them take a topical lollipop and I have them paint their own tongue. Do not poke a gagging patient's tongue unless you really want to see some bad things happen. But I will give them a mirror and I'll say, paint the back posterior lateral border of your tongue. So for yourselves, think about the area that you're doing your oral cancer screening on, right? That back corner of the tongue that we're always checking. You want to put your topical benzocaine there because most patients gag, even on a maxillary denture, because their tongue hums up and that's what makes them want to throw up. And so I do this every time. It works way better than hurricane spray. It tastes better than hurricane spray. And then you don't have the added psychological effect of their throat going numb. Because I used to do hurricane spray, then their throat goes numb. They think they can't swallow. Now they're freaking out. They're salivating like crazy. So I don't do that. This helps a lot because then they get the denture in their mouth. The numbness wears off slowly. And now they're used to the denture. Okay. I do this for impressions too on patients who think they can't tolerate impressions. The other thing that helps is a calendar. So I will give the patient a calendar. Just like if you've ever worn orthotics from a podiatrist, they tell you wear it for an hour the first day, 2 hours the second day, 3 hours the third day. And so I'll do this with my patient. And I've had patients where I said, you are going to start wearing it for 1 minute today at a time, 5 times. And then tomorrow you're going to wear it for 2 minutes. And I give them a smaller, super achievable goal. I tell them you're going to watch, what do you like to watch on TV? You like to watch Wheel of Fortune? You're going to put it in during the commercial breaks of Wheel of Fortune. And then maybe they'll forget by the time that it's in for the last 20 minutes of the show. So these are the things I do to help them. And I've had, knock on wood, success doing that way. The other thing that I would say is thin it out. So the back of a denture might come back super thick and frequently just thinning that from the cameo surface. So this is showing the intaglio surface. You're not trimming this surface. You're going to flip it over and look at the portion that their tongue is touching, and you're going to thin it to nothing. And that helps to hide the edge of the denture from the patient's tongue, because now the posterior palatal seal that you carved is squished up in their squishy depressible tissue. And now where the denture begins and their mouth ends, it's hard to tell. So now it should fit in there like really well-fitting Spanx. No lumps, no bumps, everything's hidden and comfortable. So only thin on the cameo surface, and do not adjust the posterior palatal seal from the intaglio side, that internal portion, because you risk making the gap bigger and then it'll be more noticeable to their tongue. Looseness is a really common issue that can stress you and the patient out really fast. So the first thing I do if my patient's denture is loose is I check for areas of overextension. Usually if it's loose and I had a good impression, it's because a little area is just a little far outside the bounds. So I'm going to repeat all my border molding movements, and whatever makes it pop down is the area that I need to adjust. So there's no guesswork now. You're not just looking at it like, where do I begin? Go back to your border molding movements, do them in succession, pucker and smile. Does it drop? No. Okay. Move them side to side. Does it drop? Yes. Okay. I need to thin my vestibule. Open, close makes it drop. Okay. It's probably the hanular notch is a little overextended. So that makes it a lot easier for you. Do not just jump to relining, because that's what a lot of people do. They're like, oh my gosh, it's loose, I'm going to reline. No, you might still have the same problem, because if it's overextended, the reline's not going to make the denture any smaller. Another thing that I do is I have the patient do extended movements, and I also have them speak. So if I don't get it at first, but then it's happening as they're speaking, I'll just have them talk as much as possible. But then they don't know what to say, right? If you say talk about something, they just stare at you. So I say, please tell me your name, your address, and your phone number, because those things they can recite without thinking. Because again, I want them not to think. So they're going to tell me their name, their home address, their phone number, and then I'll start to see what's making it drop, and I can see where is it too thick. The patient's tissues also might be compressed by their old denture. So if they come in with an old ill-fitting denture and then you put in the new denture, it might not fit right away. So when at the end of the day, here's another sock analogy. You take your socks off, your foot has the impression of your sock on it, right? You can see where your sock ended. But 20 minutes later, it's not there anymore. So sometimes you just need to give it a few minutes before you make too many rushed adjustments. And it's the same reason why when I take a definitive impression, if the patient has an existing denture, I ask them not to wear it for at least the hour before my appointment. And I'll ask them not to wear it for the hour before the insertion day. So impression day and insertion day, please don't wear your denture. Don't skip to occlusal adjustments right away. I find occlusal adjustments are usually overdone. I want to make sure that I'm adjusting each denture individually first. Then I go to my occlusal adjustments. Because if you put the dentures in and check the bite and start adjusting things, but it wasn't all the way up, you're going to end up now having to adjust the other side. It becomes like trimming bangs and everything gets too short. So I'll do some adjustments, make sure it's even on both sides. I like to see the patient 1 to 2 days later after they've settled in. And this is when I use horseshoe articulating paper just to make sure it's even contact. And then I see the patient again in 1 to 2 days. I don't use horseshoe articulating paper on my anything fixed, any operatives, anything like that. I use AccuFilm because it's thinner, but I do like to use horseshoe for my initial denture. If the patient is having an issue with cheek biting, that is because of insufficient vertical dimension. So you didn't make the teeth tall enough when you first started, or because the teeth are right on top of each other. So they're overlapping perfectly and they're becoming into this little guillotine for their cheek. So if that's happening, you can either grind the buccal surface of your mandibular teeth to create a 1 millimeter overhang, or on a brand new denture, regular tooth composite sticks really nice to the tooth denture. It doesn't on old dentures that have been in the patient's mouth for a while, but if that denture is brand new, you can just roughen the surface, bond, and put composite on in the same shade, and it stays really, really well. And you need your upper teeth to hang out laterally, horizontally, 1 millimeter wider than your lower teeth, because that acts to push the cheeks away like a curtain so the patient doesn't bite their cheek. But I would say the biggest thing with your dentures is that you just need to manage the patient's expectations. Don't let a patient who has restorable teeth just yank them out because it's going to be so much easier to have a denture. So when I'm managing my expectations, I often use the F word because I'm from New York, but not the F word you're thinking of. I use the word fake. So I tell the patient, yes, I can give you fake teeth, but they're not going to function like real teeth. Just like if I cut your foot off, I could give you a prosthetic foot, but it's not going to function like your regular foot. Are there people who run marathons with a prosthetic leg and I can't run a 5K with two regular legs? Of course. But it's going to take some acclimation. It's going to take time to get used to, and you can't expect it to function the way that your teeth did. So even if you walk with a limp, you don't jump to a prosthetic leg. And the same is true for our teeth. And if you can prepare the person to know what the expectations are of a denture during the other denture appointments, when I'm doing my impression, when I'm doing my wax room, I just talk about what to expect with the denture. Like I'm giving them like a little sneak peek TED talk about what to know. Then they're prepared. And then when it moves a little bit and they know they have to rinse it out after meals, they know that's the reality of life with a denture. If they come back and I never told them that, now I'm making excuses for what I made, right? So it's with everything in life, it's about you want to manage the expectations. So you always want to, under promise and over deliver. So that's the same thing I always tell my patients with my dentures. So with that, I will take any questions. Thank you so much for your time. It was really fun tonight.